Okie doke. So just trying to see if there's many people online. Oh yeah, there's one person. Perfect. Okay, hiya. I'm Sharon, VP of Mentoring, and are you expecting Dr. Quinn? She will be on in a second. I am just going to run through the PBL case with you guys, and also go through the dental questions. And then what we will do is we'll move on either to Sherry-Ann for the vet stream, and then likely on to Lauren to conclude the rest of the webinar on the medical side of things, and also the situational judgment tests and the discussions we'd had in the rest of the study guide. So everyone will have this guide in front of them. So shall I run through the scenario? So it was Thomas's 6th birthday and his mom had a big surprise for him. Just yesterday, he'd lost a tooth and placed it under his pillow, only to find a £2 coin. He's very lucky to get a £2 coin. Not many children get that for their teeth. So the day was already off to a good start. When he got home from school, there was a huge parcel waiting for him in the front room. He couldn't wait to open it, and when he did, he couldn't believe that it was a puppy. Lucky Thomas. He had been wanting a puppy for ages. He had never had a pet of his own before, and he couldn't wait to make a new best friend. His mum explained that they would all have a big responsibility to train him over the next few months, but Tom knew they could do it. Tom's first job was to find the perfect name, and he decided on Freddie, which I think is a pretty good name for a pet. His mum booked Freddie into the vets for his first vaccinations, and obviously this will make quite a lot of the vet questions will come in here. Freddie had no common puppy ailments such as cleft palates, umbilical hernias, heart murmurs, or retained testicles before giving him his first vaccinations and his microchip. The vet also discussed Freddie's diet with Tom and his mom, as well as why we vaccinate puppies and how best to care for Freddie in his new home. During the consult, they also discussed neutering and preventative medicine, such as flea and worming treatment. Tom left feeling proud of the new facts he had learnt that would enable him to care for Freddie as well as he possibly could. Now, I don't usually run this, so I don't want to be like I'm teaching you to suck eggs. I will carry on. If Sherry or Lauren want to nudge me to maybe carry on with the questions, please do let me know via the usual channels. I'm going to carry on reading this, guys, though. So it had been a couple of weeks since Freddie came into the family when Tom started to notice an annoying cough, mainly at night time, which he couldn't shift. His eczema had also flared up, and he was scratching so much his mum had to bandage his arms and legs up at night time to protect his skin from abrasions. He had multiple skin infections previously, and his mum had some steroid-containing cream which her GP had advised to use when the eczema flared up. But Tom was really struggling, especially during sports at school. He would get out of breath and running the length of the pitch, whereas before he could have run for miles. So I'm just going to kind of move towards the medic side of things. Little things like this when you're taking a history. Sorry if I'm stepping on your toes, Lauren. Will start to kind of ping in your mind in terms of what could be a possible issue. So when parents are telling you things like this, they should be kind of moving you towards kind of differential diagnoses. And the same thing would apply in vet and for dentistry as well. So history is always, majority, I don't know exactly what the percentage is, but majority of your diagnosis will be made through a history. So your cogs will be kind of ticking in terms of what could be wrong. So that's even before you've examined the patient at all. One Monday morning, Tom woke up for school with a fever, sweating and coughing. His throat was sore and he had a throbbing headache. His mom had been giving him regular Calpol that day, but knew it was time to see her GP because of how concerned she was. She booked an appointment for later this afternoon, but even before they could make it, Tom became very unwell. He couldn't breathe, he was clutching his chest, and his mom thought he was going blue. So this is the point you would start to panic, okay? As you can imagine, a patient going blue is not very good. I'll leave the medical DT who has an MD, so that's Lauren's specialty. He was using every muscle visible to help him breathe. She called an ambulance, and the ambulance arrived within 5 minutes. He was taken to the local pediatric hospital, which is helpful because they'll be specialised in treating children. And as we know, children can tend to have very, very different issues to adults. On arrival in resus, his respiratory rate was 45 breaths per minute, which is very important. His heart rate was 160 beats per minute. His blood pressure was 100 over 60, and his oxygen saturation was 84%. So all of these indications are these observations are things that you would worry about, and then collectively something very worrying. He still could not speak in full sentences, and he was still breathing very hard. An A2E assessment was performed, and he was starting on high flow oxygen, while his mum was advised to give him regular puffs of salbutamol inhaler. The junior doctor agreed he was blue and took an urgent capillary blood gas showing PaCO2 was 6 and PaO2 was 6.5, while his pH was 7.335. I will definitely leave all of that to Lauren to talk about. Tom was asked to breathe into a plastic tube, which recorded his peak flow at 150 mils, a 60% reduction from his predicted peak flow reading. He was in type 1 respiratory failure, but was at high risk of going into type 2 respiratory failure. The medical team got IV access, a yellow pediatric cannula, and started him on IV hydrocortisone, antibiotics, and IV paracetamol. They organised a chest X-ray because they could. Here's some crackles on auscultation, and chest X-ray confirmed an area of local consolidation consistent with pneumonia. Okay, all right. So a bit different to normal proceedings. I'm going to actually run into the dental side of things. So as we could see from the little bit of the scenario, Tom had lost a tooth. It was his 6th birthday, and he had placed that tooth underneath his pillow. So one of the questions here was about what are teeth actually made up of. So teeth are formed while patients are individuals still in the womb. They are formed as part of a enamel organ and the tooth bud in the jaw. You can go into further specifics with this. I didn't want to delve too far into it because this is very much something that is taught in the first year of medical school, and I wouldn't expect you to have a massive understanding of at this stage, and to a degree could maybe even confuse you. In terms of what the teeth are made up of, this is something that any of our aspiring dental students will definitely need to know. So as you know, the white bit of the tooth on the outside is the enamel. Then underneath the enamel is made up of hydroxyapatite crystals, if anyone is interested in that. It is a structure that is very, very similar to bone, but has a different percentage of the constituents that there are in bone, hence the actual difference in structure. It's a lot harder. It's one of the hardest materials in our body, if I say that loosely. Hence why our teeth are not destroyed when people unfortunately die in fires, and dental records are needed. Underneath your enamel is your dentine. So this is the yellow layer of your tooth. So if you see when people are smokers, or specifically people who brush their teeth too hard, tend to wear the enamel away, and that's when people's teeth start to become yellow, and that's because the dentine underneath is shining through the enamel, and is contributing on top of any staining that people will have had from their food. And then the actual inside of the tooth is what we call the pulp. So the pulp is the nerve of the tooth. It's the neurovascular supply of the tooth. And this is what becomes painful or sensitive when. So I don't know if you guys have issues when you have something very hot or very cold. The reason that you get an issue is the dentine of your tooth has what we call tubules in it. So little passages that run through the dentine to the nerve. So when you have something cold, it causes nerve conduction through those tubules and transfers that to the nerve, and that's why you get this short, sharp pain. When people have decay in their tooth, bacteria actually get into the nerve of the tooth, and that's obviously what causes pain, because you've essentially got decay and bacteria on top of a nerve. The reason that you get such intense pain is that the pulp of the tooth, or the nerve of the tooth, is like concrete room with 4 walls and has no area for expansion. So you may get some people saying that specifically their tooth pain was worse on a plane. It's because the pressure, it increases the pressure in the nerve, and it can make the pain unbearable, essentially. So they're the three main constituents of a tooth. You have the enamel, the dentine, and then the pulp, which is the nerve and the vascular supply of the tooth. On the outside, the tooth is attached to the bone and the gum via the periodontal ligament, so it's a ligament like anything else in the body. Okay. The next question was, how do children's teeth differ from adults' teeth? So one is the size. Children's teeth are smaller. You may have also noticed children's teeth are a lot whiter than adults' teeth. And because they're smaller, the constituent parts, so the enamel, the dentine, and the pulp, are also smaller, which means that decay spreads a lot more rapidly and a lot faster through a tooth. So a small hole in a child's tooth can turn into a big hole very quickly and turn into an infection very quickly. The other difference is obviously an adult's teeth are for life, whereas a child's teeth are, you would expect a child to have lost their teeth fully. Obviously, there's ranges and everybody's different, but a 12-year-old, you probably would have expected them to have lost all of their 12, 13-year-old, all of their primary teeth and be moving towards adult dentition. Yeah, what are the other differences between primary and there's not really much more, to be honest. In terms of structure, they're actually the same. They're just a smaller package that do the same thing. So when are baby teeth most prone to damage? Anytime, to be honest. Children can be children. It tends to be more so at a time when children are starting to learn to walk. As you can imagine, they're more prone to falling over, hitting their face. The one big thing, and I think this is another question on here, is what is the difference in the management of a baby tooth? Now, if a baby tooth comes out, the rule is 100% you do not put that tooth back in. Now, the reason that is because there is a adult tooth developing underneath that. And the root of the tooth, if you put that back in, can actually push into the developing tooth bed above. Okay. So if you say this is the tooth and that's the tooth bed, if you push this and you push it actually into the tooth bud, it's going to affect the development of the adult tooth above, and they could end up with some sort of developmental defect, staining, pits and fissures on their tooth, which parents will not thank you for. There's also certain rules. What tends to happen is when the tooth bud develops, it develops what we call palatally, so towards the palate side, not towards the lip side of the bone. So if a primary tooth or a baby tooth gets pushed backwards, that means the root will go the opposite way, which means you could leave that tooth because it hasn't pushed itself into the tooth bud. Which is what tends to happen most of the time when children fall onto their face. Their teeth are going to go backwards. On occasion, where you get injuries where a child has fallen with something in their mouth, it will actually pull their teeth forward, which would mean the root of the tooth would go backwards into the developing tooth bud. So you would make a decision to then extract that tooth because it's causing damage to the adult one. Okay. If a baby tooth comes out, you do not stick that back in. If an adult central incisor or a front tooth or lateral incisor, which are the ones on the side, if they come out as part of trauma, you can stick those back in, but there are guidelines to doing that. Okay. And they're very, very strict guidelines. It's what we call the golden hour. You have to ensure that that tooth is stuck back in within that hour. And preferably it should be kept in some sort of biological medium. So as horrible as it sounds, the best place is if the child keeps it in their cheek, or if they keep it in a pot of their own saliva or in room temperature milk. A lot of people tend to bring it in a tissue, which is not helpful, because what will happen is that tooth will get stuck back in, but the nerve will die over time. And they could end up with an infection. So we do put adult teeth back in, but there's a very strict rule in terms of when that can happen and what the prognosis, so what the chance of survival of the tooth is. So I hope that's answered that question. If anybody has any further questions on that or queries, please feel free to email me or Lauren, and Lauren can just send that email over to me if there are any questions. So in this instance, we so and I can't remember if Thomas was intubated, so but he was very much, he may have been getting to a degree where he did need to be intubated. So if you can imagine with intubation, use a laryngoscope to visualize the correct me if I'm wrong here, Lauren, to visualize the vocal cords, so that you can then pass the tube. If you're using a laryngoscope, which is a very, very hard metal object, there is always the chance that you could damage the teeth. So that's something you have to be very, very careful of, and it's something that most anaesthetists will make an assessment of before they put patients to sleep. Obviously, it's very difficult in emergency situations in research, which this very much could be. If a patient's losing their airway, you just have to get something down them. If there's any collateral damage, that's unfortunate. In a planned situation, they will make any assessment of any loose teeth, any loose dentures, any loose crowns, which could come off at the point of a patient being intubated. So there's always a risk, and that's always an assessment. So for medics specifically as well, this is an assessment that you should make with your patients, just to see if they're, because obviously if you knock a tooth out during intubation, that then becomes an airway risk and could be a foreign body that passes along with the tube. And then we're in a whole host of other problems if there's a central incisor sitting inside somebody's lungs. So, it's something you need to be very, very careful with, and it's very easily done even in skilled hands. I've come across instances where that's happened, and I've been asked to come back and put the tooth back in. So yeah, so I've spoken a little bit in terms of how do teeth form a part of an assessment. So every anaesthetist, there will be a part on the anaesthetic assessment chart which talks about dentition and any issues that could be a possible problem. Obviously, dentures and loose things like that that can be taken out, the patient will be asked to take those out ahead of time. But yeah, I think that's everything. I think that's all the questions answered in a roundabout way that which we'd asked here. If there is, I have kind of flipped through things quite quickly, and there's a vast array of information on this stuff. If anybody has any further questions about things, or would like to know any more information, please do email me or email Lauren, and she can send it over to me. And I'm happy to answer them as needed. Okay. It actually helps me to learn stuff when I have to answer these questions, so it's good. What we're going to do, guys, is we're just going to have a little bit of a shift around. So please stay on the line. It'll either be Sherry-Ann coming on next for the veterinary students, or it will be Lauren coming on for the medics. So just stay put. Don't go anywhere. I'm just going to log out and let one of the other guys log in. But please feel free to ask any questions. Or send me an email if you need to. Cool. Peace out.